Thanks. We have some time for panel discussion. Um, so I wanted to start off. We have two members of the panel, Christine Cruz from St. Jude Children's Research Hospital, Mark Denenberger from Endeavor Health, formerly known as North Shore Health System. So you might know him, but that's through that affiliation, but that's their new health system name as they've expanded. And both St. Jude and Endeavor Health have long-standing programs. So I thought I'd open it by getting each of them to give their reaction to the conference so far from the experience of kind of long-standing institutions that have had a committed program to implement pharmacogenomics. So Chris?
Sure. Thank you, James. Really happy to be here. I'm Christine Cruz, and I practice at St. Jude Children's Research Hospital. We're in Memphis, Tennessee, and we're a pediatric institution. We've had a pharmacogenomics program since 2011, and really the impetus for our program was because we have a strong discovery research program at our institution. We were discovering the associations between genes and drugs and really, cementing the understanding. And we found that it's sort of like that knowledge was just stopping at the door to the laboratory, and we weren't seeing it translating to our patients. And so, I mean, all of you being here, I mean, look how far we've come since then. So we really were among the first to just kind of push through those barriers and determine how we could offer this testing for our patients. So we do it through a preemptive testing program of multiple gene panel. And I just wanted to just kind of pull in, there were some threads among the three very different programs that presented. One of the things that I wanted to highlight is the importance of tying in this program with the strategic plan of your institution. And that's really key for, at St. Jude, we are all clinicians and researchers, and so clinical research is what we do, and so precision medicine has a top priority in our institution's strategic plan over the next 5 years, and pharmacogenomics is called out by name and in several places in our strategic plan as a place that's really precision medicine with its feet on the ground. And so we really get some leverage from being prominent in the strategic plan, and so everyone understands where we stand and the important role of the program.
Thanks, Chris. Mark Dunneberger, Endeavor Health. It'll take me a long time to start saying Endeavor instead of North Shore. I'll just recognize Dyson Wake. He's in the back. Anything I talk about for pharmacogenomics, he's probably the one that actually did it. I just get to represent us here. We have had a program for more than 10 years, really focused on preemptive implementation in the clinical setting. We took kind of the foundation that everybody else built and said, well, let's just get it into the clinic and see what happens. We won't worry about a research design. We'll generate a bunch of data, and in our free time, we'll look at it and publish. And we kind of do that, but we don't do it so well. But we have tested a lot of people through clinical care, not free tested, handed out, but over 30,000 people paid for testing that included pharmacogenomics, and it's happening 250 times a week now, just ongoing, mostly through primary care in a preemptive mindset. But now that we have that foundation, we're going back in and filling in hot spots that Deepak was kind of talking about. So in oncology, looking to make sure anybody where DPYD might be relevant, getting them done, thinking about maternal fetal medicine, what can we do there? So we have this nice baseline, and now we're really trying to enhance where else we can help to fill in those gaps. So in response to the presentations we've seen so far, there are three things that I would highlight. So Chris already mentioned this one, is like understanding the why that you're doing your program. We've seen three different whys, and I know my why is different and Chris's why is different. Understanding the why, always going back and asking that over and over and over again, because there's a lot of ways to do pharmacogenomics, and if it doesn't attach to that why, you won't be successful. You might have a program for a little bit of time. Nobody's going to be happy with it. You're going to lose your funding because this does cost money and resources. So make sure you're always thinking about why are we doing this and designing something that matches that. Number two, Deepak was the first one to mention that they don't follow CPIC guidelines to the letter of the law. Well, Good news is CPIC's not the letter of the law. They are guidelines for us to start off as a jumping off point. So as you're developing CDS, CPIC's a great place to go. But my guess is if you did exactly what CPIC guidelines told you, you're going to have a product that's not palatable for your end provider. So it's not so risque to not follow CPIC guidelines all the way. I think pretty much everybody has done that, and you saw that in the other two presentations as well. And that's something for us to think about as we look for standardization across large EMR corporations. Like, what are they giving us, and how do we make it the palatable product that we need to have? And then I'm going to have to look at my notes here because I'm blanking on the third piece. Just hold on one second. Yeah, so the other is we've looked at clinical decision support or workflows that already exist, and that's where you're starting to see a lot more uptake, right? So Amy was talking about doing it in an order set, right? Adjusting the order set you're already using with pharmacogenomic data. Don't pop up a new alert, right? And so as we're thinking about pharmacogenomics, one of the things that at Endeavor that we do, we have a population panel that we offer. So it's oncology, it's cardiology, it's pharmacogenomics. And so now we're having to think, okay, with those disease risks, where else do drugs play a role in those disease risks? And how do we start to make these look the same so that we don't have this isolated pharmacogenomic thing, but we're thinking about genomics, and then we're thinking about genomics in the context of the whole patient. And that's where we're really starting to get a lot of traction. And Josiah and Ben have a poster later today talking about pharmacogenomic implications in the ACMG list. So really excited to see that. And I think that's the future of where we're headed. And we need to think beyond the traditional bounds of pharmacogenomics and how that plays a role in what would be CPIC guidelines going forward.
Great. I like this point of the why of the programs, and I wonder if the other panelists wanted to share a little more of the history or the why of how their programs developed. Because I think that's a great point. I think that the programs have been built up, sort of the exemplar programs have been built up for different reasons and kind of different histories, and I think that's useful. So do the others have more to add on the why of their program?
So like I mentioned, I'm in our pharmacy department in our College of Pharmacy, but our institution as a whole has a precision health initiative. And one of the arms of that initiative was implementation, because we were doing sort of like what Chris mentioned, really, really well on the research side, but not actually seeing those things translate into patient care. And so that's really where the support has been and the excitement has been of, we know these things, now let's figure out how to actually bring them into our patient care.
Yeah, I don't think it would be hard to replicate, I think, what we've done at the VA, just because we were lucky to get this donation, which was a big catalyst. So the why for us was more is how do we sustain what we've been able to build through this initial kind of opportunity. I think the big whys for us, I think adverse drug reactions, medication safety still is something that resonates, across the enterprise, regardless of what specialty you're in. And so that's a theme we continually come back to for ongoing support and funding. And then we've benefited from partnering with Precision Oncology in the VA, and Precision Oncology is kind of one of our landmark precision medicine programs in the VA. And so it's been easy then to say, well, here's precision medicine for your cancer care. Now, can we think about that same concept for other things? And so that's allowed us to pivot, so to speak, to a similar area when we get into pharmacogenomics. So that's been kind of what has worked for us so far.
Great. Natasha, was there anything you wanted to add?
I think I talked a little bit about the why, but really as we continue to grow and sustain our program, we focus on accessibility. So we have a large rural footprint, and so our clinic is an example of how we have an in-person clinic, but also, e-visits where we can reach patients across our footprint, and then making that test available through primary care, through specialties, and so just making this something that's accessible to our patients is sort of our current why, I guess.
That's great. And I was glad to hear safety mentioned as a quality and safety leader. And a lot of my professional effort in that space, I think we still have opportunity as a community to further push into the quality and safety sphere to say, here is the safety value that pharmacogenomics provides. So I was glad to hear that came up several times. How about I ask the panel one question and then we open it up to the audience? What was, and whoever wants to start, what was maybe something unexpected that occurred in your implementation so far? And have you solved that, or does it remain a challenge? How about that as kind of a broad question? You can bring in whatever you like.
All right. So we had a very focused program, right? We built orders in the EHR. We were going to control which labs we used and how results were going to come in. The biggest shock to me is the number of different ways that a single pharmacogenomic result can be reported. So I'll give you the horror story of star 1, star 10, CYP2D6, and sometimes we have activity score, and sometimes we have some copy number or structural assay. That one result has been reported 25 different ways. And so that's one result of one gene in a multi-gene panel, and we have to build the logic to support that. And I'm just always impressed to see the creativity that comes through our interface. It's amazing. And so that just means that we have a lot of maintenance, and we really have to be thinking about how are we handling the results that are coming in, and always looking at them over and over and over again, because we may be able to deal with a new result that came in, but dealing with that might affect how we dealt with a result that came in 3 years ago that we weren't thinking about, and it really makes maintenance challenging, but that's a lot of work that Dyson does, so thank you, Dyson.
Other thoughts on things that were unexpected?
Yeah, so for me, I think the incidental finding space was something I didn't fully appreciate when we started. In my mind, panel-based pharmacogenomic testing is about the future. It's about future medicines, new starts. But it's a barrier to clinicians who are thinking about, again, I'm ordering this test for this patient because I want to use this test result tomorrow or in the next month. And I really don't have the bandwidth or the expertise to look at all the medicines that they're on, and I don't want the liability. And even in a setting where liability is less of an issue in the VA, that's part of the culture amongst the healthcare community, that that you're responsible. You order a test, you're responsible for it. And so, so solving that has been something that we've had to be really creative about. We're still not there yet. We think we have some solutions through technology, information technology, through pharmacists, through some of this population health management, and I'm hoping that will help alleviate providers' concerns when it comes to incidental findings. And then I think it'll also deliver better healthcare as well, because I know already now we know things are getting missed because the pop-ups don't come up until the prescription is touched. So there's always a gap between the time the test result comes back and someone touches the prescription. And if it's a high-risk interaction, and in not all patients, but in some patients, there's probably a good case to make an intervention, but you need to know about it and have someone, a clinician, who can actually act on it and communicate it back with whoever needs to be communicated. So that's been, I think, a lesson for us over the last few years.
Yeah, that's great. Other thoughts?
Yeah, one other specific thing. This will be something that's very familiar to probably many of you in these seats. So when we built our individualized CDS alerts, starting in 2011, we built them in our longstanding EHR system, which was Cerner, never expecting that we would migrate as an institution to Epic. In late 2022, we migrated to Epic. So all of our work that we had specifically built in Cerner, we had to take that work and try and streamline it into Epic. And if the thought of that doesn't strike fear in your heart, then you've probably never been through it. So I'm just really proud of the efforts that we put in by planning well ahead of time, and by working as a team, and by really setting our processes to be EHR independent. We had processes that stood the test of migrating them into the new setting. And I'm happy to say that we didn't lose any footing. We were able to replicate and get up and going with a lot of effort by a big team. But if anyone's doing something similar, happy to talk to you later today.
Great. I think we have time for one or two questions from the audience. April, bring around the mic. I see one over here.
Hi, Steve Scherer from Baylor College of Medicine. So Dr. Vora, I wanted to sort of pursue one of the things that you brought up, and that was that you had actually are moving from a pre-testing to a reactive model. That's sort of counter to every talk I've ever given, trying to sell the whole concept of pharmacogenomic testing from a clinical workflow perspective. And so I'm curious as to the sort of the underlying thinking behind this. You did mention cost, but in the grand scheme of medical care, pharmacogenomic testing is, frankly, dirt cheap. And so I guess I see this as, especially in a large government paid for healthcare system, as being moving in the wrong direction, if you will. And then generally, I kind of like to ask the panel, how do you handle VUSs if you're doing sequencing, where you've got a VUS that's like a stop code on an exon 2 and CYP2D6, kind of thing, where it's never been seen before, these private mutations, right?
Sure.
Do you flag them?
Yeah.
Do you, et cetera? Anyway.
All right, so Deepak first, and then the panel for the VUS.
Yeah, no, it's I get the sentiment. I think again, the theory of preemptive testing, I think, is the right one, right? Test early, test broadly, store the results for when they are needed, and I still think that's conceptually the right way to go. I just don't think the model, at least in the VA, where a provider has to order the test, I think most providers aren't thinking preemptively. Maybe outside of primary care, they're not thinking preemptively, right? And so for me, it was pick your battles, right? And so, and if I'm trying to change the way providers practice medicine, I need to meet them where they are and in terms of what they're willing to do. And so we could have built a whole new model where, we just do this outside of kind of routine medical care and do preemptive testing, maybe at entry or as part of some, like a vaccination type program, right, where it's like a public health type program. That's a very different model, not to say that we couldn't pursue it, but it seemed, at least as a clinician, as a physician, my goal is to change the behavior of my peers, right? One of my mentors would always say, our work isn't done until we stop calling it precision medicine and we just call it medicine. And so to me, that's why we've kind of pursued this approach of trying to get frontline providers to change the way they practice medicine by integrating PGX into what they already do. Not necessarily to, if we wanted to get more patients tested, we would have picked a different model. But I also think that, being a payer of taxes, that right, I'm a steward of taxpayer dollars as well now, and we need to make sure that we're doing what I think is the most value-based medicine. And I think doing this hybrid approach where you're doing a large panel, it may be for a targeted indication, so it's kind of part reactive, but it's also part preemptive. We can store all of that data and make it available for this longitudinal relationship that we have with our patients, which for us is, is 4, 5, 6 years. And so we thought that was kind of the sweet spot.
That hybrid point is I like that it's not quite a stark, you're either doing preemptive or reactive, that you are using the data over time. Yeah. All right, and then a couple want to say something quick about the VUS point as well? No, we don't. You don't have any? Okay.
So we avoid the issue because we take our sequencing data and basically turn it into an array through bioinformatics and only look at certain places on those genes so that we don't have to deal with this problem. But it is a problem that is going to come and affect pharmacogenomics phenotyping better and understanding more about being able to predict the protein effects of individual mutations and how that might actually impact clinical care will become a problem at some point that we have to tackle.
All right, April's got a question in the back.
Yeah, so this was going to be a question for Deepak, but maybe for all of you. When you decide if you're doing this drug gene pair by drug gene pair, how do you balance the evidence versus cost versus the prevalence of use, et cetera? How do you make those choices to prioritize a particular drug or gene?
Yeah, I think great question. We have a little bit of flexibility in the VA because we're not a reimbursement-based model. We're a capitated system, so we can make certain investments that others can't. I mean, for us, it's really about clinical validity, clinical utility. I think those are the two big questions. So we ask our subject matter experts to weigh in on those and review the evidence. And if they think there's sufficient clinical utility, then we then can move ahead with designing a program around it. I don't think positive predictive value hasn't come up so much as an issue. Cost hasn't come up so much as an issue, again, because we're doing this hybrid approach where we're testing for the, not only for that one drug, but the value of that test can be monetized over the course of the life of that patient. So that so far hasn't been so much of an issue with our providers. But I think that also comes from the fact that we can be responsible with the data. So we can take all the data stored in the system, make it available, and when providers know that, then there's less burden about testing patients quote unquote unnecessarily, kind of thing.
I think Todd had a question over here.
Thanks. Todd Score from Indiana University. I think initially a question for Deepak, but maybe everybody too. You showed what looked like a nice decrease in the discordant medication versus genotype, the concordance between that. As we're measuring things like that, it's always good to have a goal in mind, what we're trying to get to. And considering, like I think you mentioned and Mark alluded to, there are reasons why they shouldn't be concordant, right? Tolerance and contraindication and stuff. How do we do you have a goal in mind for what that line should be and how we can figure that out without going into every single patient and seeing, whether there was a contraindication or something like that?
Yeah, I don't know what the right answer is. And maybe it would be great to develop like some benchmarks that universally were accepted, right? Of like, in terms of what the discordance rate ought to be and some accepted reasons why it would be okay, and then use our CDS to fine tune that, right, and target education. So we haven't developed any benchmarks as of yet. Right now, we're just doing this very kind of crude pre-post type design, and there's probably variability within each drug, right? Some are going to be more than others, but yeah, I don't know if anyone knows the answer. I think the closest is that from the PREPARE trial, where I heard, at least anecdotally, that at least in the intervention arm, 2 out of 3 times there was concordance. I don't think they've presented what the metric was in the control arm. At least I haven't seen it. But if that's what it takes to get a 30% relative risk reduction in adverse drug reactions, it's a reasonable place to benchmark. It could be better, but like maybe that's the minimum, right? That's a place to start in my mind.
So kind of adding on to this, just looking at discordance versus concordance undersells probably a huge value of pharmacogenomics. So we know from our clinic that there are patients that their pharmacogenomics and their drugs line up perfect. And we didn't do anything, but we can talk to that patient and they will tell you there was a lot of value in the discussion and doing pharmacogenomics. So as a field, we have this big challenge of defining what are the true value points of pharmacogenomics that drive to real clinical outcomes and real clinical benefit. This is one step there. And then the other reason why I don't want that to be the driver is we've been looking at our data, and as we get out to 5 years after the results have been available, our discordant rate starts to tick back up. And we don't know why. So I hope that's not the be-all, end-all, because we got a big problem.
All right, I know we've got lots of questions. Let's take one more right up here, and then we'll head towards lunch.
Hi, I just want to maybe switch gears here. Yusuf Roman here, and thank for you, Amy. I really appreciate the work you're doing, especially in the transplant world. When it comes to transplant, we're talking about not just the recipient now genomes, we're talking about the two genomes. We're talking about the donor and the recipient. And a lot of work in population PK modeling and a lot of these things, it matters what the donor's genotype is and how it can impact precision medicine and precision dosing. Have you considered specifically tacrolimus in this case, given that CYP3A5 is actually expressed in the renal tubules, the donor's genotype might have an impact? Has that been looked at?
Yeah, so great question. It was not something that really was feasible with the group at the time. Again, as I kind of mentioned with the question about are we doing panel testing or single gene testing, we had to do a lot of baseline education with providers and just what is the relationship between the recipient genotype and the medication and what is the value of that. And one of the other concerns of the providers is, genotype is a big part of the story, but it's not the whole story. Other medications, patient fluid status, patient stability, all impact tacrolimus dosing over time. And so I think it's the question of what percentage does that new variable contribute to that dosing in terms of modifying what your dose recommendation is going to be. And so with our initial implementation, we just didn't feel like it was a big enough piece of that overall puzzle. And our best value was going to be just looking at that recipient genotype. And like I mentioned, we're going to try to refine to continue to improve this. And maybe that'll be a variable we can look at in the future.
All right, so help me thank the panel. Great presentations and discussion.